Hi everyone, welcome to Module 2, Assessing the Evidence for Emerging Practice Models. What we'll be covering today is assessing current challenges, needs, and possibilities in clinical social work, and then moving into heuristics and practical judgment, so strategies for selecting practice models. I just want to say at the beginning that because of the size of these files when I audio over, I'm going to try and split them into two. That way they save easier and it's better quality. So this is part one, and then you'll notice there's a module 2, part 2, which is the rest of the PowerPoint. Okay, so we're going to talk about the use of evidence-based treatments in social work. A longstanding problem within the field of mental health, as well as health, is the lag between bench to bedside. So what that means is the transport of treatments that have demonstrated their efficacy or effectiveness. So they've been studied, they've found to be effective treatments for whatever mental health condition. But their uptake in clinic settings or in real life settings is slow, if at all. So estimates suggest that it can take upwards of 2 decades before new treatments that have been shown to be effective in a laboratory setting or in an effectiveness trial become part of standard practice, if at all. And another issue is that very few treatments that are initially adopted are sustained over time. And this may be due to a host of factors. There may be financial reasons why sustaining an evidence-based treatment is not feasible. Perhaps that a grant had supported the adoption of a given intervention in a clinic setting, and then once the grant funds run out, it becomes difficult to sustain. Also, there may be changes in agency funding streams, incentives to, say, adopt a certain practice might discontinue, and in that case, it may be too costly to sustain that practice over time. So the end result is that very few treatments that are in evidence that have been shown to be effective for mental health conditions are adopted, and even fewer are sustained within real-world clinic settings. So the National Institutes of Health, which is the major federal funder for many of the projects that seek to test an intervention and its effectiveness on a certain mental health condition, they're very invested in closing this gap between bench to bedside. In 2014, for example, they dedicated over $125 million to look into studies to develop effective treatments for mental health disorders. So they're also invested in dissemination of those. And as we'll talk about across the semester or throughout the semester, there are, excuse me, there are different ways in which you can assess dissemination, adoption, and sustained utilization of these practices, as well as the barriers and facilitators to uptake. But the result being that if it takes up to 2 decades before these treatments reach those in need, if at all, that really means that people who are in need of these therapeutic interventions aren't receiving them, and that the mental health service system is lagging behind in terms of the administration of best practices by up to 2 decades. So you might be asking, what is the role of research in social work practice? Well, the NASW Code of Ethics mandates that social workers have an obligation to keep current with emerging knowledge related to social work and to fully use evaluation and research evidence in our professional practice. Additionally, a social work core competency is that we engage in research-informed practice and practice-informed research. And what does that mean? It means that we engage in practice that is informed, at least partially, as we'll come to learn, by research about effective therapeutic interventions. And it means that as researchers, we are conducting research that is based upon or emanates from our practice. So this is, in a way, when we talk about engaging in research-informed practice and that we keep current with the knowledge base, it is akin to the conceptualization of a consumer of research, which assumes that we have knowledge about research methods and can evaluate research. So this is basically, this slide just gives you an overview of the 3 research roles that social workers can assume. Um, and to engage in practice-informed research would be more along the lines of a creator or disseminator of research. However, what we're really talking about here is that we keep current with and that we are a consumer of research in order to inform our professional practice. So as a consumer of research, you might engage in several activities. You might keep current with certain journals. Maybe you have a subscription in your specific area of expertise, and you may actively keep current with that literature. Or you may have a client that presents with a specific mental health problem or issue that you're not quite familiar with in terms of what is the best therapeutic intervention for that disorder or problem. And in that case, you would conduct a literature search of the most effective treatments, say, for a child with anxiety. However you consume social research, the assumption is that you have access to, say, a search engine to conduct a literature review, or that you have access to journals. And journals are costly. And if you're not affiliated with a university or some other institution that has access to these search engines, it would be highly difficult for you to do one on your own. Additionally, you need knowledge about how to assess the rigor of the existing literature base. And that is something that can become very complicated. So you would need to be able to critically evaluate the rigor and the substance of the literature, taking into account factors such as the sample size, the methodology, how the data were analyzed, what the findings were, and so forth. So another issue in social work is that there has historically been a great divide between research and practice. And there's many reasons for this that you, if you did even a basic search, you could uncover. But we do know that there is a well-recognized split between them, and that manifests in career paths. So if you are involved in a research career versus a practice career, your training is different, your education is different, and the professional work you do is different. So the key issue, though, is the extent from which we can use research findings to inform clinical practice when there is such a great divide. Alan Kasdan, I believe in 2015, wrote an article about how we can make research more accessible and palatable to practitioners. And within that, he mentioned things such as, well, at the bottom of every research article, you put practice points in there. It's the implications of that study upon practice and so forth. Well, that's absolutely helpful, but we need to do more, and we have to ensure that practitioners have access to and have the education to be able to critically appraise this, the research base. So before we go any further, it would be helpful to clarify, what do we really mean by evidence-based treatment? So you'll hear that phrase quite a bit, and you may also hear evidence-based practice and evidence-based intervention. And all of these phrases can be quite confusing, and they've been used in confusing ways, and some would say interchangeably. They're not interchangeable phrases. So let's talk about what is an evidence-based treatment. It is an intervention or a technique that is shown to be an agent of therapeutic change. in some sort of study, be it an efficacy study or an effectiveness study. So it is an intervention or a technique that's produced some therapeutic change in controlled trials. For example, cognitive behavioral therapy as an evidence-based treatment for anxiety. Evidence-based practice is different. It is clinical practice that is informed partially by evidence-based treatment. So what is the existing evidence regarding maybe the most effective therapeutic intervention for anxiety, in addition to the clinical expertise of the practitioner and the client needs, values, and preferences. So when you take all three of those aspects into consideration, you are considered an evidence-based practitioner. And that practice is evidence-based practice. So Ruffalo's book deals with this quite a bit. The whole model behind her book is that of the evidence-based practitioner. And what an evidence-based practice or practitioner is that you are actively considering multiple sources of information, including your own expertise in the decision-making about a given intervention. Now, there are critics of evidence-based practice, and part of that is that the sticking point is on the clinical expertise, as well as the rigor in which you as an evidence-based practitioner would be assessing the effectiveness of a given intervention that you're implementing. Okay. So critics would say, look, we know that cognitive behavioral therapy works for anxiety. That is a well-studied and effective therapeutic intervention or evidence-based treatment for anxiety. But we don't really know much about evidence-based practice. And we don't know about how a practitioner would utilize their knowledge or their clinical expertise to make a decision rule about what therapeutic intervention they would adopt. And there's lots of other things we don't know about that model. And it makes the critics of evidence-based practice uneasy with this as an approach. However, the criticisms go both ways. So you will hear commonly individuals who have concerns about evidence-based treatments say, yes, they've shown to be effective in research trials. We get that. However, because you tightly control so many aspects of those studies, including who is eligible to participate, how the intervention is delivered, by whom, and so forth, that it becomes too narrow and not generalizable to the needs of complex individuals with complex needs. So that's one main criticism you'll hear. You'll also hear that evidence-based treatments focus too much on the pathology. So they focus on symptoms and diagnoses, and they don't focus on more positive or empowering outcomes. Additionally, in addition to generalizability, which we talked about, there's a lack of focus, according to critics, on individual characteristics of the client, such as their culture and how their culture may influence expression of mental health issues as well as treatment preferences. There's a pretty substantial body of literature that suggests that in my area happens, is child mental health. So we examine caregiver perceptions of the child's treatment. And what we find is that those process factors, including the perceived relevance of treatment, satisfaction with their child's treatment, and belief that that therapeutic approach will actually make a change in therapeutic outcomes, all of those factors are associated with retention and treatment and the child's therapeutic change over time. So critics would argue that if you don't focus on that then you are, in a sense, providing a therapeutic intervention that may fail mainly because there's not buy-in or there's dissatisfaction or the individual doesn't perceive it as being helpful to them. So it misses key aspects of that individual that could potentially affect outcomes. On the other hand, um, individuals who have concerns about evidence-based practitioners and evidence-based practice, and we've talked about this a little bit in the previous couple of slides, is the concern about how does an evidence-based practitioner make the decision or judgment and use their clinical expertise about what therapeutic intervention to try. Additionally, if an evidence-based practitioner modifies or tailors the given treatment for an individual or a condition, critics have concerns about that as well. How are you making those adaptations? If you do adapt an intervention, how can you ensure that you're still remaining, that you have fidelity to that intervention so that the core effective elements are still there if you're tailoring it? Also, critics are concerned about how the evidence-based practitioner evaluates outcomes. So when they test this intervention or evaluate it and measure it, how are they doing that? Another concern is that there's a use of treatment that has no or very little evidence base behind it. So how do we deal with that? What if you are combining different therapeutic approaches? So in the real world, you'll hear providers say, you know, I use a little bit of parent behavior training in addition to some CBT. So it's culling of different therapeutic interventions into this eclectic approach. And a critic would argue there's no evidence base behind that eclectic approach. And finally, generalizability. If you have an evidence-based practitioner that is using their own clinical expertise, tailoring an intervention in their own way, and using an amalgam of therapeutic approaches, how can you possibly generalize that to other individuals with similar difficulties? Not to mention, and on both sides of this, all of the other factors that go in when you're considering implementation of an intervention. So we have to consider characteristics of the provider. We have to look at aspects of the organization in terms of adoption and utilization of evidence-based practice or evidence-based treatment. All of these factors, therapist, the therapeutic alliance, countertransference, any potential bias that is occurring. All of these factors play a role in delivery of any intervention. And how do we account for them? Regardless if you're following an evidence-based treatment model and you're a proponent of that, or if you're a proponent for the evidence-based practitioner. So the model of being an evidence-based practitioner is growing in popularity across schools of social work. And we have pretty articulated responses to those critics who would argue that about generalizability or using interventions with no evidence base, or the other criticisms that have been levied against this model. So for the first one, the concern about decision making or judgment and how you use your clinical expertise. We would argue that the same way in which a researcher discovers knowledge through the positivistic perspective is how we as clinicians come upon our knowledge. We observe. When a client comes in weekly, we observe and assess changes in their symptoms due to whatever intervention we are using at that moment. There was an author, and her last name is Cooper, and she wrote an article in the 80s, which I can dig up if anyone's interested, about trying a very psychodynamic therapeutic intervention for her client. And she was noticing that that client made great strides in her initial presenting problem using that therapeutic approach. But the client also engaged in a series of ritualistic behaviors. And Dr. Cooper decided to try a different therapeutic modality to address those. So she tried cognitive behavioral therapy, and she tracked the number of ritualistic behaviors over the course of the therapy that she was conducting with the client. And what she found was that over time, as she was administering CBT, the number of ritualistic behaviors decreased significantly. That's an example of how we come upon our practice expertise and wisdom. We observe and we track, very much like a researcher would. In terms of how do we tailor treatment to meet the needs of individual clients, there are many standardized ways in which we can do that. There are models that we can incorporate that walk us through how to systematically adapt an intervention while maintaining fidelity to that intervention. We can also look at theory, and we'll talk about that in part 2, and use theory to guide any kind of explanation as to why we believe this tailored intervention was effective for a given outcome. Or we can use different methods of assessment in the beginning. For example, Weiss and Torpeda developed the top problems. And what that is you basically ask a caregiver, what are the 3 top problems that you see, with your child that you would like to change? And then you address. So you implement a therapeutic approach that is actively addressing those problems. So that's another way in which we can tailor interventions in a way to meet the needs of our consumers and to do so in a systematic and standardized way.